But okay, so let's start. What we're gonna discuss today is basically cardiac emergency is really, really important. And a lot of people um, mess up on like these really, really easy things. But it's really conceptual, and we'll just go through them super quick. Oh yeah, Google Drive, sure. That's a good suggestion. Okay, so we're going to discuss pulseless arrest, bradycardia with a pulse, and tachycardia with a pulse. So very important is for you guys to realize what the difference is between having a pulse and not having a pulse for the first part, and then we'll go into recognizing certain EKGs and sort of having an EKG crash course of sorts, which is specific to the MCCQE because the MCCQE doesn't ask you really difficult ECG readings. Like a lot of the crash courses out there, they're like they're big into identifying the kind of waves and stuff. They just want you to identify basic things like VTAC or like flutter or stuff like that, or the types of heart block. So we'll go over all of that. And at the end, we'll also tie in ODs because they can give you a complicated patient where he is overdosing on, for example, a stimulant like cocaine, and they can give you an EKG. That would be a slightly higher level. Um, but uh, but yeah, we'll go through it and you guys will be pros at the end of it. Okay. So first, this is probably the most important slide. Um, what happens when you have either a VFib or a V tachycardia with or pulseless VTach pulse. So that's what it stands for, VFib pulseless VTach, or you have pulseless electrical activity or asystole. So very important is for you guys to know that asystole is not shockable. And this is a very common misconception. I don't know how many of you guys watch Grey's Anatomy, but I literally saw them shocking an asystole in Grey's Anatomy. So you don't do that, okay? You first have to push epinephrine. So what you're gonna be asked is something like a scenario probably where EMS is on their way. They've already started CPR in the ambulance, and they've already started oxygen, all of these things. So they're probably not going to ask you, should we start CPR? Because that's kind of easy. Like you have to start CPR right away. And in real life too, you probably get an EMS guy coming to you in his ambulance, and CPR would have already been starting en route, right? You have to know what to do as soon as the patient reaches the hospital. And so let me try and do some drawings here. So, so first to know is the rhythm shockable? So like I said before, asystole is not shockable, and I think a lot of like TV shows where they show you like patients flatlining, what do? You grab out your defibrillator and you shock him. That's actually wrong, and this is from the American Heart Association, the Heart and Stroke guidelines. Like, stress me on this, you don't shock asystole, okay? Um, the the rhythm that you shock is VFib and pulseless V tachycardia. Okay. If your patient is one of these two, then you bring out your defibrillator, you shock him where you go, everybody clear, and then it shocks. That's a little bit different from something called cardioversion. That's also something that we'll touch upon, is a difference between defibrillation and cardioversion. They're similar, but not exactly the same. So this shock that I'm talking about here is where you actually get those two pads, you charge it up to, say, 200 joules, you put it on the patient's chest, and you say, everybody clear, and it delivers a shock. That's what we're talking about here. And then obviously, once you shock the patient, everybody clears, so you have to stop CPR. But as soon as the shock is delivered, you continue CPR. And there again, probably won't ask you this because it's kind of easy. to know that you have to do CPR all throughout, even if it's asystole, you have to do CPR. So when you see in movies and TV shows that they start CPR right away, that is correct. Okay. Um, let's say you shock the patient, you continued CPR for 2 minutes, and it still shows either VFib or pulseless V tachycardia. What do you do then? Then you shock one more time. Okay. There is a possibility that after you shock and you keep doing CPR, the ECG changes. It can either be a normal ECG or it can be a non-shockable rhythm, basically. So this would be like a normal ECG I'm trying to do over here. Not very good job, but if it is a normal ECG, what do you do? Any guesses what you would do if you shock the patient and he's fine? Do you think you give him any drugs or continue CPR or anything like that? Any idea? So then you achieved something called ROSC, which is return of spontaneous circulation. So if you have a normal ECG, that means you've achieved ROSC already, and you're good to go. Then you just keep your patient under your watch, and you make sure that he doesn't go back into it. And it can be like your patient can also go into something like this. It can also go into something like pulsus V tachycardia, which is what we will discuss. And then you just follow the guidelines from there, which is why I have these guidelines over here. You don't have to memorize a lot of things. You just have to follow the guidelines. You have to know which rhythm is shockable and etc. So let's say your patient is still in VFib, you shock him one more time. So as you can see here, you shock for a total of 3 times before you push amio or lidocaine. Now, a lot of the times, if you're using your logic, you would think that, oh, like amiodarone and lidocaine, they seem like reasonable drugs to give in arrhythmias, but you have to know when to give what, right? So if you give amiodarone or lidocaine before epinephrine, in this case, it is going to be, you're going to get the question wrong, right? You have to first give epinephrine. And in this will be part of like the crash cart, which you see. I don't know how many of you guys have worked in the ER already. You'll have an EpiPen there, not an EpiPen, sorry. You'll have epinephrine loaded probably already by the nurse. You'll have amio, you'll have maybe lidocaine. Sometimes you have only one option between these two guys because, like you see, it's an or case. So it's also based on like hospital preferences, provincial criteria, all of that. But if you give amio or lidocaine before epinephrine, it's not going to work. So there will be a timer, like a person who will literally time you, so you don't have to worry about this. So let's say your patient arrived at 1 o'clock and you shocked him right away. Let's say you're perfect and you do it at 1:01. You continue CPR for 2 minutes, so it's 1:03, and the patient hasn't improved. So it's 1:04 right now, and you shock again. Let's say there's like 1 minute in just transferring the patient or something like that. So it's 1:04 and it's still where you shock him, still not improved. You do CPR for 2 minutes, and then epinephrine every 3 to 5 minutes. So there will be a timer who will literally tell you, you have to direct this timer because you're the doctor in charge, but you literally have to say, timer, tell me every 3 to 5, or you have to probably say either 3 or 5 minutes. Tell me when it's 3 minutes are done, I want to push epi again, right? Let's say you shock the guy 3 times. You have to tell your timer then, timer, let me know when 2 minutes of CPR are up. I want to push amio or lidocaine, right? So this all is really, really important for you guys to know because they probably won't ask you too in-depth of a question, but if they tell you that, Mr. Brown is a patient, he's coming to you, his pulseless VTAC, and EMS has just arrived, what do? And you say, I want to push epi first. That is incorrect, right? You're probably going to kill him because you have to shockable rhythms. Conversely, if you say, Mrs. Brown, she had VFib in the EMS when she was getting transferred, but now she's in your hospital. She's on the bed in your hospital and she has flatlined. Okay, she's gone like this. What do you do? If you say, I want to shock Mrs. Brown, she's not gonna make it because you have to do epinephrine ASAP. So as soon as possible for asystole, you push epinephrine, continue CPR for the most part. They will already attach an IV in the EMS. You don't have to stop CPR for epinephrine. So just continue epinephrine and don't shock this patient because like I said before, I think I said it like 5 times, you cannot shock asystole, right? Because it's not going to do anything. Because what does shocking do? Can anybody tell me, like, why would you shock a patient at all?
To go down to baseline.
Exactly. So you need to like target the QRS complexes, and this the machine will do for you to get your SA node working again. But if it's asystole, you don't have any like peak to target. The machine doesn't have a peak to target, so it's just going to be like, oh, I don't know. It's probably going to deteriorate the patient even more. So you just give epinephrine, you do CPR, and you check if that does anything, right? It's very possible for your asystole to be converted into a shockable rhythm and vice versa, right? There are like arrows everywhere. Um, if it converts into a shockable rhythm, which it could, you shock. If it does not, then you can just continue CPR. Honestly, at this point, if Mrs. Brown collapsed in her apartment and she's transferred by EMS and she has asystole for like, say, 10 minutes that it takes to get to the hospital, she's probably not going to make it. But if your question says, what do you do? And you say, I want to shock her and not give epinephrine first, you're going to get that wrong. And that is quite the mistake to make as a doctor, honestly, because I mean that says you don't know which rhythm is shockable. So now you guys know. If the rhythm um is not shockable still, you just continue CPR. And after a point where if it's still asystole, you patient won't be probably making it. Okay. Any questions on this slide at all? Okay, I'm going to go to the next one. So another thing that your patient can convert to is, we'll go back to this one, is bradycardia. So again, all of these are tied in, and I wanted to do this all in one slide because your patient can convert into anything, and they're going to ask you the next step, and all you have to do is memorize or just know what you do given like which step you're at. Okay. So let's just go over maybe this slide super quick. I just put down some pointers, and this is on the group as well. So you need to know VFib and pulseless V tachycardia are shockable rhythms. As soon as, I mean, you can have even a bradycardia patient convert into one of these. As soon as it converts into either of these two, you have to shock them. And that is defibrillation and not cardioversion. So if they want to really confuse you, they can even give you both of those things as an option, right? They can say, oh, like, what what would you do? Would you defibrillate or cardiovert? It's defibrillation. We're going to talk about cardioversion in a little bit. It's slightly different. The monitor kind of looks the same. People can get that confused, but now you're not because you're part of this class. Um, Antiarrhythmic drugs are considered after a second unsuccessful defibrillation attempt in anticipation of a third shock. So the wording, the reason I put this here is because the wording can sometimes confuse you. So look at this slide, right? You shock the patient one time, shock the patient 2 times, and then you give him epinephrine. So let's say they word a scenario in which Mr. Brown has had 2 unsuccessful defibrillation attempts. What would you do in this scenario? Anybody quickly answer that for me? Mr. Brown has had 2 unsuccessful defibrillation attempts. He has VFib. What would you do? What drug would you push according to this table?
Keep CPR.
Epinephrine.
Yes, exactly. Keep doing CPR and epinephrine. So both correct answers. Let's say your MCC words this question a little bit differently. Let's say after 3 consecutive defibrillation attempts, Mr. Brown is still, let's just say it's after 3 unsuccessful defibrillation attempts and after pushing epinephrine, Mr. Brown is still in VFib. And they give you like amiodarone, and then they give you epinephrine, and continuing CPR probably isn't like an option there. What would you do?
Amiodarone.
Yes, exactly. Good. So now you guys know. And again, they could also call it refractory VFib. So if you say 2 defibrillation attempts have been done in refractory VFib, what would you do? It's epinephrine. So don't get confused by that. Refractory just means you've tried something and it didn't work. Amiodarone is the first line. Lidocaine, it can be an option given like what hospital you are, what they like to use, all of that. They probably won't ask you the doses, but lidocaine is just 1 mg per kg. And let's talk about magnesium sulfate. Now, magnesium sulfate is something that you use for polymorphic VTAC. So, monomorphic VTAC, like it says, it's the complex looks the same. So if it's like it looks the same, I know this doesn't look the same, but your EKG will be like, okay, your QRS complex, they kind of look the same. They're twins. Let's say you have like a wide complex and then a narrow complex and then a narrow complex and then a wide complex again, or something like that. That's called polymorphic VTAC, and it'll be like smushed together, so it'll be a VTAC. What you do in that case is that you give magnesium sulfate, especially if you've, for the most part, you will have already tried epinephrine and lidocaine. If that doesn't work and you're getting like weird QRS complexes, you try magnesium sulfate. Okay. But for the most part, it will not go to this. But if they ask you, what is, like I said, this is a maintenance infusion. Okay, that's very important to note. You don't start with magnesium sulfate. Don't, that's why I like put this at the very end. Like if your Mr. Brown comes and he has polymorphic VFib, don't start him with magnesium sulfate. Okay. You just have to continue it as a maintenance infusion. So the question that they will ask you is, let's say another patient, Mr. Smith had, he came with ventricular pulseless, let's do VFib. You give him 2 shocks, you give him epinephrine, you give him amio, and that has cured his polymorphic ventricular tachycardia. What drug would you give next while he's recovering? That would be this guy. Okay. So now you know everything you guys need to know about shockable rhythms, really. There's not any further detail that you guys would need to know. That's for cardiac to answer when you page them. Next thing will be adult bradycardia. Okay, so let's say Mr. I don't know, Mr. K. He's come and all of these will be done again by the EMS team. You don't need to worry about that. You just need to know what your heart rate is. And again, they could give you an EKG for this. Very few cases where they would actually give you an EKG to read and interpret. One of them is the rhythms we discussed over here: VFib, VTAC, asystole, and pulseless electrical electrical activity is your best friend. Okay, it's your best friend. Why? is because it could be anything. It could be literally anything apart from these two. And if you have no pulse, you follow this, right? So yeah, those are really simple. You guys already know that. Bradycardia, I suggest not to actually go ahead and count all of those boxes. You just have to go with your gut. If you see EKG, which looks like it's really, really spaced out, um, obviously there's like a formula of like the big boxes over 300, all of that. But just go with your gut. If you see very far away complexes, just it's bradycardia, okay? Now you have to know what you do in bradycardia. So for the most part, they will give you a patient who is unstable because if it's just a normal person with less than 50 heart rate, it could even be just an athlete, right? Because they have a lower resting heart rate. They will probably make your patient unstable because you have to worry about this patient. If you have a completely normal patient, it could be like they're a runner or something, right? Any signs of crashing or anything like that, what you give is atropine. Okay. Now another thing to make a distinguishing line over here is that you might think epinephrine is a great idea, right? Because we used it right back there, right? You might think, yeah, pushing epi is a great idea. I mean, sure, but you have to give atropine first. Okay. So this is where one of the only times where you actually have to memorize that. Okay. Um, so atropine first in bradycardia. If atropine is ineffective, then you do transcutaneous pacing. Now, what is transcutaneous pacing? That is something that is confused with defibrillation. So what is it? So I'm attempting to draw a person here. So this is the person's chest. You will have one pad over here and one pad over here. And it's not anything major like, oh, I'm charging to like 200 joules, everybody clear. Like, no, it's just going to be two pads. It's going to again like target the QRS complexes, just make the rhythm go back to normal again. It is not quote unquote shocking the patient. All right. So they could ask you, Mr. K comes in with bradycardia. He is also hypotensive. You have pushed atropine already. It does not cure his bradycardia. What would you do? Option A, transcutaneous pacing. Option B, defibrillation. Option C, CPR. And option D, nothing. What would be the answer here?
Transcutaneous pacing.
Exactly. Very good. So yeah, this is something that's really important and really basic. But a lot of people like they're like even 1 week out to give their MCCQE and they don't know this. And they ask you this, like they ask you stuff like this, and you're supposed to know this. So that's why I wanted to go over it and hopefully make like a resource on everything that you do need to know for the MCCQE. There are a lot of resources out there that is more catered to the USMLE because I'm guessing more people take the exam, and there's a lot of stuff you don't need to know for the MCCQE. Like, and even the question style is a bit different. Like, if this was a USMLE question, it would be like this big, and you have to somehow find out what is happening. And the MCCQE will give you like one sweet little line and these four options, and you need to know. Okay. So I'm gonna ask you questions and like get your brain more accustomed to this. Because hey, I was the person who did U World all the time, and the MCCQE is different. So yeah. Okay, I wanted to put this slide in because a lot of people might get confused if a pregnant woman shows up. All you have to know, if a pregnant woman shows up, you have to basically do the same thing. Basically do, so this will already be done in the EMS. Depending on what she has, don't get confused like, oh, she's pregnant, I can't push epinephrine. Oh, she's pregnant, I can't push this. No, you basically do everything that needs to be done for a normal human And because again, who is your priority, guys? Your priority is the mom. Even if she loses the baby, it's fine. This is an emergency. This is like one of the biggest emergencies of their life. This is a life or death like situation. And if you end up saving the baby and losing the mom, it's considered unsuccessful. Like you were unsuccessful in your mission, which is your number one priority, which is saving the mom. So if you get a question that says, oh yeah, Mrs. L comes in, she's pregnant, she's 9 months pregnant, like she's completely up to term, and she has V tachycardia. Nothing doing. You have to treat her like a normal patient, okay? Don't get confused just because she's pregnant, okay? The only thing that you can do is perform obstetric interventions. You don't change patient plan, okay? So you can do like, you can do continuous lateral uterine displacement, detached fetal monitors, basically like if you're shocking her, don't have fetal monitors attached. Prepare for perimortem cesarean delivery, like page, gynac, you can do all of those things, but do not change your normal way of doing things, okay? I just wanted to put that in there so you guys don't get confused. Okay, any questions so far at all? Don't feel free to raise your hand or ask me anything if I'm going too fast, or I can repeat things too. I know this is quite a lot, depending on how much you've studied already, but all of this is super, 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 super high yield. Probably one of the highest yield things I'll do. So please stop me if I'm going too fast. I did do this one before this class, but I think a lot of people hadn't joined, so I think it's only fair to redo this for everybody. Okay, I guess no questions. We're going to go forward with adult tachycardia with a pulse. Because remember, if your patient has whatever, like she could have like insane tachycardia, but no pulse, all you have to do is CPR. Okay. And again, you don't do CPR for a normal with pulse guy. Even for bradycardia, you don't do CPR. Okay. And I guess that's important to know, like when to do CPR and not, even though it's the EMS guys who are doing it, like you have to know and when to continue CPR and all of that. And these are all in the guidelines, okay? So let's say Mr. M comes in with adult tachycardia. And again, I would suggest not to go ahead and count those boxes. Just go with your gut. You see an EKG that looks, really smushed together. It's tachycardia, okay? So again, these things will be done by EMS. It will probably give you an unstable patient, but if they don't, that's fine too. Let's say Mr. L is unstable. He has he's confused. Okay. So what do you do then is again synchronized cardioversion. So it's like kind of like the same, but the drug that if synchronized cardioversion doesn't work is different. Okay. You can consider sedation if Mr. L is really confused or if he's, agitated or stuff like that. And then you have to see the complex. So there are two ways in which tachycardia with a pulse can present. It's regular narrow complex, or it can be a wide QRS complex. Now, this is really simple. Literally, wide complex looks like this, narrow complex looks like this. Narrow complex is more common, so it's probably what'll show up. If it's wide QRS complex, like literally all you have to do is remember you do not do synchronized cardioversion first if it's wide QRS. Is that clear to everybody? Just remember that, because this is a very easily testable thing and it's a really easy answer, honestly. But a lot of people don't know. Like if you have like a wide QRS complex, think like a lot of people are, it makes sense to like cardiovert this person. No, it doesn't. So the question will be, Mr. M comes in with a wide QRS tachycardia. What would you do? Option 1, cardioversion. Option 2, defibrillation. Option 3, adenosine. Option 4, CPR. Anybody can answer that for me?
Adenosine.
Yeah, exactly. Very good. So now you guys know, right? The flip side of the case is that he has regular narrow complex, which is like the normal tachycardia that you guys are used to seeing on an EKG. You do synchronized cardioversion, right? If that doesn't work, or if it's really, really serious, you can consider pushing adenosine as well. Again, YQRS, you do not cardiovert. You push adenosine, and it's most likely going to be regular and monomorphic. If it's not, then it's probably slightly more complicated, and you have to see if the rhythm is, you have to check the rhythm, rule out heart block, all of that. For the most part, they won't give you something that's too complex. So just know the difference between these two. And again, like that's why they say expert consultation, right? Like wide QRS complex is very uncommon with regards to adult tachycardia with a pulse, and you do have to page cardiac to rule out other things like heart block and stuff. Okay. And again, if that doesn't work, again, page cardiac and consider antiarrhythmic drug of your choice. There's no, rule of which one you have to do, but just you can probably give something like procainamide or amiodarone, whatever is in your hospital. But just remember, this is the steps you need to follow. Don't cardiovert wide complex. Okay. Any questions at all for this slide? Oh, I almost forgot. If your patient is fine, he looks fine, like he's not crashing, he's not confused, he's not anything. He doesn't have a wide QRS, which basically means he's this guy. Like his EKG shows that he's narrow complex VTAC, but he's fine. What you do first is you ask him to do vagal maneuver. Okay, and then you kind of like just do the same, give adenosine and a beta blocker or calcium channel blocker. Now, can anybody tell me what an example of a vagal maneuver is? There's so many, right?
You can apply some pressure in your eyes.
Yes.
Blowing the balloon.
Yeah, anything else?
Carotid massage.
Yep. Anything else? Those are all
Coughing.
correct. Yeah. Blowing a paper bag even can be one of those, right? Straining or basically asking your patient to like try and poop, that can be one of them. So they could actually give you that as one of your things, right? They could be like, what would you do? And one of the options of the vagal maneuvers can be like that, like ask your patient to blow in a bag or carotid massage or anything like that, right? So you have to choose that one. Okay. I hope all of that is fine. No questions there at all. Okay.
Sorry.
Yeah.
Yeah, sorry to take you guys back. I didn't get that part. Like the indication for the vagal maneuver. You said that he's fine, but he has a wide QRS complex.
No, he does not have a wide QRS complex. Basically, the vagal maneuver is when you have an EKG that shows tachycardia, right? But the patient looks fine. Like, the reason you can't ask him to do a vagal maneuver to start with is he's confused, or he has, signs of shock, or he's completely hypotensive, right? You can't ask that kind of patient to do a vagal maneuver. You can't be like, okay, I know you're like completely out of it, but I really need you to try and like blow in this bag, right? That is why you don't ask him to do it right away there. Now,
Yeah, I got it. Thank you.
yeah, okay. So that's when you ask that's the scenario in which you ask him to do a vagal maneuver. Okay. Now, now that we've gone through the various types of EKGs, you guys know what bradycardia, tachycardia looks like, and all of those other guys. Pulseless VTAC will basically be like a normal VTAC, like it'll be like smushed together, but it will be no pulse. And VFib, I probably should put a slide there, but it basically looks like maybe as homework you guys can see what VFib looks like on EKG, okay? So you guys know all of that. I just want to go over types of heart block, okay? So there's first degree, second degree. Second degree is split into Mobitz type 1, type 2, and there's also complete, right? Now the let's start with the third degree because it's actually the simplest. Third degree has no relation between the P waves and the QRS. So if you see there's a P wave without following QRS, you're like, okay, interesting. Let me see the interval between the P and the QRS complex. It's really wide over here. It's like 2.5 boxes. This is my next P wave. There's like 1, 2, 3, 4, 5, 6, 7 boxes in between. So already there's no rhythm again. This is my next P and this is my next P. There's like, it doesn't make any sense. There's no pattern whatsoever. That's third degree. Okay. And in all of these cases, you will give an antiarrhythmic and page cardio. Let's do now second degree. Second degree is also pretty easy. The Mobitz type 1 is also called the Wenke back. Okay, so I like to remember Wenke is W. It like winks at you. So basically, it like almost like teases you, like, okay, yeah, it's going longer, it's going longer, it's going longer, and then you dropped it, right? That's how I like to remember it. I know it's like kind of silly, but works for me. So if you see the progressing of the PR interval, and then suddenly it drops, that's Wenke back. Okay. Okay. Now next, let's talk about Mobitz type 2. Mobitz type 2 is also very easy. What you have is a fixed PR interval, and then suddenly, out of nowhere, you have a dropped beat. Okay. So you're looking, okay, I have an interval of 1.5 boxes, 1.5 boxes, looks regular, 1.5 boxes again. And suddenly, all of a sudden, I need a QRS complex to be here, but it's not. And then, okay, again, like it's almost the same, like almost a box. Like it's not like progressing in length like it is over here. It's just out of the blue, a QRS complex is dropped. That's type 2. Okay. First degree is also very simple. It basically means that your PR interval is more than 0.2 milliseconds. And honestly, I don't think they will ask you to diagnose a first degree heart block. It just means that your P wave and your QRS complex is very, very far from each other. Okay. And that's it, literally. Any questions at all on heart blocks? Because I mean, for the most part, you do have to memorize what they are and what diagnoses them, but like, I mean, it's easy. You guys can do it, and all you have to do is give antiarrhythmics, right? Okay, I'm gonna go to the next slide, and the next slide is a question for you guys. Let's see if anybody can answer it. So, despite 2 defibrillation attempts, the patient remains in VFib. Which drug should you administer? Very, very easy.
Epinephrine?
Yes.
Epinephrine.
Yeah, very good. Okay. Despite the drug provided above, continued CPR, patient remains in VFib. Which other drug should you give?
Immunogen?
Yes, exactly. Very good. Okay, you have completed 2 minutes of CPR. The monitor displays a lead to rhythm below. Patient has no pulse. Okay. What is your next step? They love asking this. What is your next step? They'll normally give you something in that, in the flow chart. They'll give you a certain point at which you're at and then ask you the next step. So what is your next step here?
Is it to do CPR again, like for 2 minutes? Or oh,
Yeah. So when the question kind of says like your team resumes chest compressions, right? So with chest compressions in place, what is the next thing you do is you administer epinephrine again. I'm gonna go maybe back to that slide. Here. This is what you were dealing with, right? You give epinephrine ASAP, and then you continue epinephrine every 3 to 5 minutes. In this branch, you don't give any other drug other than epinephrine. So that's basically what they were asking you, like, here, because it's pulseless, right? So that it was that branch, and you just continue CPR and you give epinephrine until your patient is dead, or he hopefully gets resuscitated. Okay. So like I said, pulseless rhythm is like your best friend. You can have anything, right? But no pulse, just CPR, epinephrine. Okay. They're probably not going to give you epinephrine and CPR. I mean, most definitely they will not give them both as an option because you have to do both of them at the same time. Like I said, like there will be somebody on the patient doing CPR, and then there will be a timer, and you as a doctor have to tell a timer, tell me every 3 to 5 minutes, or whatever, say like pick a time, like every 4 minutes, tell me when it's every 4 minutes, because I want to push epinephrine every 4 minutes. Okay. Okay. See if you guys.
Sorry,
Oh
one
yeah,
question.
yes.
Is there any criteria in which you base your decision to do it every 2 or every 4 or every 5 minutes?
No, don't worry about that. Like literally, because the reason I say that is because um it depends on hospital policy as well. So when you join a hospital, and depending on your attending, even your attending can be like, I like to give epinephrine every 3 minutes. Another attending can be like, I like to give it every 5 minutes. Whatever it is, as long as it's within 3 to 5 minutes, you just have to tell your timer this, and you have to know that you have to give it, right? For the most part, a lot of people just don't know, right? Like in asystole, they'll be like, I'm gonna get out my defibrillation pads. No, right? Um, you just have to know the basics. Like I said, in cardiac, you can go all over the place, really in depth. They won't ask you all of those nitty-gritty details. They just want you to know basic things. Don't chalk asystole, don't defibrillate somebody without a pulse. Okay.
Thank you.
Yeah. Any other questions at all? Okay. Gonna go. Okay. Next question. A patient. So these are the types of questions that will actually come to you in your MCCQE. Okay, guys. There won't be like a long question stem. Like if there's a USMLE, they probably include like blood lab work and probably 2 EKGs on like different time points. They're going to give you like a couple of lines only. This is the maximum, probably. Okay, so a patient presents to you in the ED with onset of dizziness and fatigue. What does this mean? This basically means he's crashing. Okay, it means he's unstable. On examination, heart rate is this much. Blood pressure is low. Again, crashing, that means. Oxygen saturation 95%. What is the appropriate first medication?
atropine?
Yes, very good. Awesome. So I guess a lot of you guys might not have known this before your class, but what happened there is that he was experiencing bradycardia, and he was like showing signs of, crashing or potential crashing. First, just push atropine. So really good. It's awesome. Okay, now we're gonna go really, really quick into ODs because they can very easily tie it in. In fact, if I were making a question, I would probably tie it in a little bit. So let's take your previous patients. Let's take Mr. L. He's also a chronic alcoholic. Okay. Let's say or let's make another patient. Let's say Mr. M. He was in for a liver disease. Let's say he has cirrhosis, really advanced stage. He's a chronic alcoholic, and after 24 hours, he goes into delirium. Anybody can tell me what's happening here? It's probably signs of alcoholic withdrawal, right? Because he's a chronic alcoholic. He doesn't get his alcohol. He starts showing signs of delirium. What would you give to this patient for his symptoms?
Diazepam.
Lorazepam?
Okay, I heard two answers. One of them was diazepam, one of them was lorazepam. The reason I asked you this is because um our patient had, like I said, like the end stage liver cirrhosis, right? Really bad liver cirrhosis. It could be even like not that bad. It could just be liver cirrhosis. So basic protocol says you give diazepam, but if he has severe liver disease, you give lorazepam. And there are a bunch of benzos that are not that are through the cytochrome pathway, and they're a little bit easier on the liver. Lorazepam, oxazepam, temazepam. Okay. If any of these are in your options and the patient has a liver disease, severe asthma, or respiratory failure, this is what they're testing you, and this is your answer. Okay. Is that clear to everybody? Let's say Mrs. M. She came in for a knee surgery because she had severe osteoporosis, and she's a chronic alcoholic. And one day after her surgery, she has delirium. What would you give her? She's not like, and she's like a young patient. Let's say she's 50. Okay. You just give her diazepam. Okay, you don't need to worry about these guys. You just need to worry if your patient is really, really old, severe liver disease, asthma, respiratory failure. Okay. So you would start with lorazepam. Then you can give haloperidol if he's like seeing things, or any other atypical antipsychotics if you want. And you can give diazepam as a seizure prophylaxis because haloperidol, which is only in the case where you actually give haloperidol, it lowers seizure threshold. But again, what MCCQE is probably going to ask you is that they're going to be like, okay, Mr. L, he's coming for cirrhosis, but and he has an operation. One day after, he's getting, signs of alcohol withdrawal, basically. But they're not going to spell it out to you. They're going to be like, oh, he starts seeing things. He becomes agitated. He becomes confused. What do you give him? First line, diazepam, lorazepam, some other benzo, or nothing. Counseling. So your first thing's going to be lorazepam, right? If they want to make it really complicated, they can be like, okay, you've given him lorazepam and haloperidol. Where's another drug that you can add to the regimen? Diazepam. Okay. But they're probably not gonna, again, ask you for a lot of things. But now you guys know. Now you guys know what to do. And you know all of the scenarios and stuff. Okay. Another thing that they can ask you is that, well, so alcohol doesn't really cause EKG disturbances. The other drugs that we're gonna go right now into, they do. So don't be afraid if they tie it in, because you know everything. Okay, you guys know everything. You know that when your pupil constricts, like for example in a movie when like a scary animal is out to, I don't know, hunt somebody down, his pupil constricts. And why is that? It's because it's the adrenergic system, and he's really excited and stimulated. All of these things basically cause that. So heroin, morphine, oxycodone, fentanyl. Fentanyl might be a really good question to ask because it's a really big problem. I don't know if where you guys are situated at, but in Calgary, where I am at, it's a really popular like street drug. A lot of people die from it even. So they ask you that, just know it's a stimulant. It makes your pupils constrict. Methadone, codeine, and hydrocodone, they're like the more I don't know, like old school drugs. Fentanyl is sort of kind of like upcoming in the last 5 years, become really popular. They could say a patient comes into you with constricted pupils and they'll give you like maybe some other thing. And what they can do is they can ask you, what drug do you think he's on? They could give you fentanyl, and then they could give you all of these drugs that actually cause people dilation, right? And you just have to know, like, and which one causes this and which one causes dilation, okay? Dilation is when you're with amphetamines, methamphetamines, cocaine or crack. Again, like just try and remember what like according to pop culture what it does to you, right? Cocaine makes you like hyper alert. So what that does is it dilates the pupil to let more light in because you're hyper alert, right? And so does like amphetamines and opiates and all of the like high functioning drugs. Like when people are like, oh yeah, I microdose cocaine, it's because they want to be more alert and they want to be more aware. So I don't know, try not like memorize them like completely. Like a lot of people also like microdose mushrooms and LSD. Basically, it makes you hyper alert. I'm guessing most of you guys haven't tried them yourself. I haven't either, so that's how I kind of try and remember it. Because they can very easily ask you, like a patient comes in with this pupil and they'll give you a bunch of drugs and one of them is not like the other, and you just have to pick them up, okay? Redness of eyes is caused by weed, obviously. Cocaine or crack can also do that. Benzos can also do that, and depressants can also do that. This is probably something that is not very like important to you because like redness of eyes can be anything. You do have to remember the pupillary actions because I mean it can be as easy as like literally one of these things is not like the other. Okay. Okay. Opioid. There is an opioid crisis in Canada right now. And so they might ask you what opioid overdose looks like. You just have to remember these three things. It's a triad. This is straight from Toronto Notes. It causes respiratory depression, altered mental status, and meiosis. So remember opioids, like, I don't know, the way I remember is I remember opioids, a lot of like historically, mothers used to give opioids to kids to make them sleep, right? So it basically causes everything to be down in the breast. So just remember it like that. Okay. Try and remember any sort of anything from pop culture where it's related to drugs and tie that in. Try and not like rote learn or memorize everything. You have to know what opioids are. A lot of people don't know all of these are actually types of opioids. Don't get confused if they tell you, oh, he's taking a bunch of Tylenol, because Tylenol 3 is actually, it contains codeine, right? Which is kind of crazy that you can just get that over the counter, but it's something that happens. A very, very popular NAC scenario can be counseling on opioids if the person is already addicted to opioids. You guys already know yeah, the importance of giving them like a naloxone kit and all of that. And I want to discuss this further in the classes that are catered specifically to the NAC. And but yeah, you guys need to know all of these things. For example, patient comes in and he's a ex fentanyl addict, and you want to give him Tylenol 3. You need to know that that's a red flag. Okay, you need to know you have to monitor this patient really well. Okay, that can also just be a really easy question for them to ask you, right? Like, Mr. R comes in. He was a fentanyl addict. He was homeless, and he's asking for Tylenol 3. You have to be like, listen, I cannot do that. I need to either have it like pharmaceutically administered, which means a patient comes into the pharmacy and gets a drug only under the pharmacist's supervision, or, I need to make sure I don't overdose him on Tylenol, only give him like, if he needs 10 for 10 days, only give him 10, that sort of thing. Super easy, but if you guys forget that fentanyl is a type of opioid, you guys are going to miss out on this question, okay? Methadone, meperidine. Again, this I think I literally copy pasted from Toronto Notes. You need to know opiate receptors is what they act on. They also act on the dopaminergic system, and that is responsible for their addictive properties. Most likely won't ask you something on like the pathophysiology, but this is what it is. Also, they love asking you brand names, but only ones which are really, 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 really common. You guys need to know Percocet is a type of opioid, okay? And so is Vincodine, and so is Oxycodone. These are the three most popular. Just know these, okay? I think it's a really fair question for them to say like, oh yeah, he's on Percocet. And you're like, what is Percocet? You need to know. It's an opioid, okay? Just these three, okay? It's not a lot to ask. And in your practice, you will also get to know it because most of the patients, they say the brand name. So just those three you need to know are opioids, okay? Another thing is ADHD. Typical question. Oh, we got something in the chat here. I'm confused. Okay, mention their pediatrics. But let me just go back there. Sorry. So morphine will cause pupil constriction. Let me just see what the question is. Morphine and other opioids mentioned under mitotics, and opioids will also mention other mydriatics.
Yeah,
Okay.
right under hallucinogens,
Right,
there's
right, right,
opiates.
right. So okay. I'm so glad you pointed this out. So prescription painkillers. We got another chat here. What are opiates? Are they not opioids? Yes. Okay. Let me just clear this out super quick. Okay. So morphine is a painkiller, and so is an opiate. Okay. But they do different things to your pupils. Okay. So prescription painkillers, for example, opioids that you get over, like, doctor prescribes them to you, and people overdose on them. They will cause pupillary dilation. So for the most part, like, let me go to these examples over here. So you just need to know heroin, morphine, oxycodone, fentanyl, methadone, codeine, hydrocodone. It causes pupillary constriction. And opiates, which are basically, opiates are opioids, they're under the same class, but that's why they said prescription painkillers over here. Okay, so let me just go here. So, for example, so opiates would be like this, like a prescription painkiller, like if he overdoses on Percocet, right? Or oxycodone, right? I don't think that was in, oh, it was here too. So when I'm kind of confused too. Let me just get back to you guys on this one. I will get back to you on the pupillary thing for oxycodone and prescription painkillers. I'll get back to you guys in the chat on the pupillary action of these. Okay. Thanks for asking that though. But yeah, I'll get back to you. I don't understand why that this is from the internet. I don't understand why that happened. Okay, amphetamines now. So typical scenario would be a mom has a kid diagnosed with ADHD. She comes in with symptoms of euphoria, she probably won't say improved concentration. She'll say like hyperactivity, almost mania-like characteristics, right? you just have to know that, again, brand names, Ritalin and Adderall, those are the only two real brand names you need to know. And crystal meth, which is a street drug. It's an amphetamine. And I know we've come to not trust this a lot, but causes pupillary dilation because, again, gives you hyper alert, more light coming into the eyes, but you want to be hyper alert, like cocaine and stuff like that. Anything that makes you hyper alert will cause pupillary dilation. I would honestly remove this from here because I've always known like things that like kind of like depress you, like fentanyl and stuff, which is honestly, it's called a zombie drug because it makes you look like a zombie. It causes pupillary constriction. So if anything, I would just disregard this. If I give you a better answer in the chat, I'll update that, but I think this is wrong from the internet. This is just from the internet. Okay. For the most part, your opioid addict will have constricted pupils. Okay. Anything that, because I mean, just logically, anything that makes you hyper alert will cause your pupils to widen. Okay. But again, I will check that and make sure. It's in Vyvanse. Yeah, you're right. Vyvanse is also a common brand name for ADHD, correct? So yeah, like I don't want to butcher your name. Nusaipa, like Nusaipa said.
Yeah, that's correct.
Vyvanse,
Safe.
yeah. Vyvanse is also a really common brand name. They can give you that. And I don't know how many of you guys are going for the NAC. They can give you drug names in the NAC. Like for example, even asthma, like common drug names. Maybe I'll have a class on just like brand names because you don't want to be completely stumped when they're like, oh yeah, the patient's like, I'm on, let's say like Miss Harper said, I'm on Vyvanse, and you're like, what is Vyvanse? You know? So just really common things that you need to know. So you're getting back to, I don't know who asked the question about the pupils. Iram. Unless I correct myself later in the chat, I would just say opioids cause pupillary constriction, amphetamines, methamphetamines, cocaine, and hallucinogens, which make you hyper alert, cause dilation. Okay. Hope that answered your question. I should remove that slide because obviously that's from the internet. Maybe there's an explanation why they put both of those things there, but yeah. Okay. If you take a lot of amphetamines, for example, if the mom of the kid who is diagnosed with ADHD takes a lot of amphetamines, what can happen is it can actually produce psychosis, which can wrongly depict signs of schizophrenia. So again, in your neck, I'm shifting more towards the neck side because ODs and like addictions probably it's pretty common to see that in your neck. You have to rule out drugs. Okay, so if you have somebody who's presenting with signs of psychosis, you're like, oh yeah, this is a psych case. And then you completely switch to psych without even asking, are you taking anything at home? Okay, that is not, a multivitamin. And you're like, oh yeah, you have delusions, and you spend like 5 minutes asking what her delusions are and trying to diagnose it. You miss out on asking, could you possibly be taking anything at home? Okay. I have a question. OP withdrawal, maybe? What is that with regards to? Oh, you mean like psychosis? Yeah, sure. Yeah, you have to ask everything. Like, were you like in the NAC case, if your patient is showing signs of psychosis, you have to rule out a lot of things. And I want to do a separate class on this, like I said, for the NAC. But yeah, if she's doing psychosis, don't go straight to like hereditary causes because it could be anything. It could be OP withdrawal. It could be any withdrawal, any drug withdrawal. It could also be she's taking amphetamines. Okay. And the treatment, there's no treatment like a naloxone kit for opioids per se. It is just you treat whatever she's presenting with. So if she is presenting with acute signs of psychosis, you give her antipsychotics. She's very agitated, you can give her a benzo. She's tachycardic. Again, this is why I wanted to tie it in. If you have a patient who comes in with tachycardia, you basically follow that same protocol. Okay. It depends on what the question looks like. Are they focusing on the amphetamine problem, or are they focusing on the adult's tachycardia with pulse problem? And what kind of complex is it? Have they even provided that kind of information? Have they even provided like an EKG? But now you know everything, right? You guys know how to tackle anything that comes your way so far. And I think this is the last slide on common club drugs. You just need to know certain things that I've already highlighted. If you own Toronto Notes or you own the ebook, just highlight this same things. Don't really need to know the mechanism, but you need to know just certain things. MDMA, also called ecstasy or Molly, again, your patient can, it's very fair that he comes in saying, yeah, I took some Molly last Friday. You need to know that that's MDMA. What it causes is it's another excitatory quote unquote drug, so it causes all of these symptoms. Something that I wanted to highlight is it causes jaw clenching. So they could very easily say that a patient comes in, he's experiencing jaw clenching, and then he goes into rhabdomyolysis. What do you think the drug is? Or he goes into DIC. It's probably MDMA. And that is like a really common thing. Like even on the like if you guys are in a big city, you see somebody on like the train station with this, I've definitely seen it. He's probably on these drugs. Okay. We're gonna go straight into ketamine. I'll come back to these two. Ketamine, also called all of these drugs, probably won't ask you this, but ecstasy and Molly are pretty commonly seen. Ketamine, what it does is it just causes psychological distress, accidents due to intensity of experience. So basically, it makes you dissociate. It makes you feel like you're not in your body, all of that sort of things. And the thing is, it's very unlikely that ketamine will kill you. So they will probably name some of these symptoms and be like, and maybe rule out some of these symptoms and be like, what do you think it is? Probably ketamine. Okay. Got a question? Oh yeah, Dr. Sorry. Is your name DRA? Dra? Causes of meiosis and mydriasis. She's done a really nice thing on in the chat where it says meiosis versus mydriasis, and like I said, all opioids cause constriction, and that part in that slide is probably just wrong. Like this part right here, it's probably, I would just ignore this. So yeah. Okay, coming back to the street drugs, really important is also meth, like this also called speed, meth, chalk. What does meth do? It basically makes you really violent, raging. So if you see an angry patient, you should, and it's looking like a OD question, your mind should go to methamphetamine, okay? And it also shows a really peculiar thing called formication, which is basically, oh, I feel like ants are crawling on my skin. I feel like there are worms under my skin, or they're itching themselves uncontrollably, right? That is a stimulant. And if it's a stimulant, it causes pupillary dilation, okay? PCP or angel dust. Again, you just have to know one thing, and they will always give this to you. This is the only drug that causes horizontal or vertical nystagmus. Okay. Is all of this okay? Like I said, I'll go back to this. So this is a type of diazepam, flunitrozepam. It is commonly used on the street. That's why it's here. It's just a diazepam. You just have to know. It causes depression, like all diazepams. Especially if you combine it with alcohol, it can be pretty bad. It's also commonly used as a date rape pill or a roofie. So normally they might in your NAC they might give you a case scenario where a girl comes in and she can't remember. Okay, and she's like, maybe she's asking you what happened to me, and you have to explain to her that maybe somebody put something in your drink. And to avoid that, just always ensure you cover your drink. So that could be like a good counseling case to have. Probably have a class on like counseling cases in general for the NAC, but yeah, this is one of the common drugs that's used to um, take advantage of young women, and then they wake up and they're like, I don't know what happened, but I feel like I might have been assaulted. So it's just one of the drugs. Liquid ecstasy or gamma hydroxybutyrate, again, is a stimulant, causes all of this. It also causes jaw clenching, but so you just have to know MDMA and this causes it. Normally, if they give you something like jaw clenching, they'll give you like 4 options, right? And one of them will be MDMA. They won't give this as a drug. They might give you this, 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 and this. So you just have to know one of these things is not like the others, right? They won't confuse you and give you two things. And again, they can always add a cardiac emergency in the case scenario of a OD. Okay. I think that was the last slide. Any questions on anything at all so far? I'm going to maybe stop my screen sharing and